Prasanna, we'll just hold on for 3 minutes and then start.
Yes, yes. I'm also nervous today.
Why? Why? Why are you nervous?
Because people like Prabir, Anand and are all joining. So
Okay, should we start?
if you want to give 2 more minutes, it's okay.
Sure, we'll do.
Okay.
Okay,
Shall
I
we?
think we can start. Yeah. So, welcome to the third session, friends, of Economics, Politics, and Health, the Dissection. Thanks, Prasanna, again for taking this session, even though you are traveling across time zones. Uh, Before we start the session, I would just like to remind everyone that this is aimed to be a non-hierarchical space for co-learners. Respectful and constructive dialogue and discussions encouragement is encouraged, and your engagement is the indicator of your interest in continuing these sessions. So please ask as many questions as occur to you. We are all at different levels of learning, so there is no question that is too small or too big. And if there's something that's beyond the scope of this discussion, we can always figure out a way to answer those questions in other ways, like the discussion forum that is present on the learning management system. I will send the link. It's there in the poster as well, but I will send the link again in the chat. Um, So these sessions were not designed for necessarily for doctors or economists, but anyone who would like to explore how health, economics, and politics intersect. I will also be sharing a feedback form, and I'll really appreciate it if you could just spend a minute on it after the session. Just a quick summary of the last two sessions. In the first session, we discussed social determinants of health. We discussed and tried to understand the Whitehall study and social gradients in health, education and health outcomes, the impact of social determinants of health on equity, and the importance of addressing structural issues to improve health outcomes, some concepts of fairness, equity, and justice, some definitions of politics and politicking, and concepts like scarcity, Adam Smith's notion of the invisible hand. In the second session, we discussed market economy, some laws of supply and demand, some key definitions like welfare state, socialism, communism, social democracy, liberalization, GDP, taxes, and health outcomes. We discussed something called the tax to GDP ratio and how it determines how well a nation's government directs its economic resources. We discussed addressing structural issues in health, market efficiency, and the government's role. And towards the end, Prasanna discussed concepts like charity, endowment, and entitlement in relation to education and health. So now we are on the third session, and the plan is to discuss public-private partnerships and explore how those relationships work. Yeah, over to you, Prasanna.
Two things, Gayatri. In addition to telling the qualifiers like respectful and all, open, respectful and all, you should also say provocative when it comes to my session. Anyway, second thing is accidentally I went through the first interaction we had when you got in touch with me telling people have questions about how World Bank came into health and all. That was the first question with which you started. And I thought it might, now that people have a good grounding on the various political economy structures, I thought I will start with explaining a little bit about that and then get into the private sector engagement, not necessarily only PPP, but what is this elephant called private sector I would like to deal. Okay, so I might not be able to complete the whole debate today, but yeah, I will try and be good. As usual, please hands on the buzzer. Also, I see that the novelty factor has come down and people's feedback has come down. I have not seen an updated feedback after the second session, and even the discussion forum hasn't been utilized. Please feel free to shout, argue with me. Yeah, that's the prelude. Okay, so the question was from Gayatri, which started this series, was why and how did World Bank come into play? So I thought I will start with our favorite, all-time favorite, Almata. Pardon me, Prabir, and Anand, all of you. Anyway, yeah. So what is Almata Declaration? Anybody hands on the buzzer? Oh, sorry, I'm not projecting. No. Yes, please, hands on the buzzer. Almata Declaration.
A commitment to primary health care.
Okay. What was the principle? Philosophy, principle, whatever. Primary healthcare was a strategy.
That health is more than just your indicators. And it's not just the medical system, and that there are aspects of, let's say, education, the social determinants in what we discussed that affect health. And therefore, they need to
be that is true. But that was... Sorry, continue.
No, please go on.
So, but that is true. That was already in the 1948 constitutional document of WHO when it gave that great definition of health. So what was the principle of Almata? What did it outright, at the outset mention?
Community participation, community-based
Strategy.
solutions.
That was again a strategy. I'm asking the principles. Okay, what was the basic declaration about? Fundamental anyway. What was the headline declaration?
Health for all.
Correct. By 2080. That was in 1978. Yeah. So what were the principles? Okay, let me go through. So fundamentally, it reinforced, restated that health is a human right. Of course, it was there already in the UN Human Declaration of Rights and all, but Alma-Ata reiterated that. And it emphasized on equity and social justice. Those were the bedrock, what you call, principles of Alma-Ata Declaration. Yeah, strategies were new economic order. I'll come to this a little. Intersectoral collaboration, that is convergence between various departments, appropriate technology, and comprehensive primary health care along with community participation. Anyway, but more importantly, it called for governments to take action. Please note this. Every line of Alma-Ata Declaration says the governments shall, like that. So if you look at the Alma-Ata Declaration, I didn't have time to put in an image of the declaration, but if you read that, it's all about governments shall. Okay. And then I outline the 8 components of comprehensive primary health care. Sorry. So if the Alma-Ata Declaration is calling for equity and social justice, what is it then telling? And human rights, of course. You can combine all the 3. If Alma-Ata Declaration said health is human right and it should be based on equity and social justice, what is it in effect? What sort of a statement is it? Technical, medical?
Normative statement.
Sorry?
It's a normative statement, taking a position.
Yeah, but what position? Normative is a mild word.
One which centers, it is political in the sense that it's centering human rights and social justice.
Yes.
So that's what.
So it was a political statement, out and out. Okay. Also to tell that governments should take action, governments have the responsibility and those sorts of things. Now, till then, WHO was largely a technical body. It was giving technical guidance to nations to tackle malaria, to tackle whatever, typhoid or diabetes. And diabetes wasn't so much then. To tackle some of the communicable diseases and all. So WHO was largely a technical body telling how you should treat tuberculosis, how you should get rid of smallpox and those sorts of things. 1978, the then Director General, Hafdan Mahler, who had a history of an experience of working with the National Tuberculosis Institute in Bangalore, he said, talking about tuberculosis and treatments is just mopping the floor. So we should talk about the social determinants. We should talk about the politics of health. And there was a debate whether the conference jointly held by UNICEF and WHO, whether it was to be held in New York or Alma-Ata. Where is Alma-Ata?
Kazakhstan.
Yes. And in 1978, what was Kazakhstan part of?
USSR.
USSR.
Which ism?
Which?
Communism.
Communism, socialism. The very fact that Alma-Ata was chosen over New York was a political statement telling that health is a social phenomena. Are we understanding this? Okay, so let us look at it a little bit more. I mean, I do it very crudely. Please pardon me, but this is all written in literature. Even though I narrate it as a story and it might be a little patronizing, this is all written up in literature. So I'm not concocting stories. Okay, before this, how many of you know WHO's operational mechanism? How does WHO operate? Where does its funding come from? Or generally UN, how is UN funded?
Member nations?
Yeah. Based on
From
what?
their global partners.
That's a recent phenomena. How is UN largely funded? One is, as Gayatri said, governments, yes. But on what basis? People seem to be still warming up. What is the basis?
Is it GDP?
Yes, GDP is a big, what you call, calculator, so to say, for the contributions. So, for example, if $100 are coming into UN largely and WHO specifically, depending on the GDP status, $22 come from United States of America. 15 could be from Canada. I mean, I know United States exactly. The rest of them are, I'm just giving you an idea. India could be $1. Togo could be 20 cents, like that. Togo, Burkina Faso, heard of these countries? Yes? So a Burkina Faso, a Congo, a Kenya might be giving 10 cents, 20 cents sort of contribution. United States gives $22 out of $100. Clear, all of you? Largely, the higher GDP nations give more contributions. How is the voting pattern in WHO? If any voting has to happen, how does it happen? If a
There are,
resolution has to be passed,
yeah, there are permanent members and temporary members.
that is UN. But WHO, how does the voting pattern happen? Even largely, of course, even UN to a certain extent. Yeah, sorry. Equal voting rights as in, Anand?
All member countries have equal voting rights.
So it is one country, one vote. So irrespective of your contribution to the organization, your voting is one country, one vote. What Anand said as equal voting rights. Correct? So now let us look at World Bank. What is World Bank per se? Quickly, what is World Bank?
It's a bank.
It's a bank. So what is the funding pattern of banks? Hello? How do banks raise funds?
From
Oh, sorry,
people
somebody's.
who have
Sorry, I'm not
invested.
observing. Yeah,
From
what do they
people who
invest?
have invested in the bank.
Like dollars, or they become
Yeah, yeah,
shareholders. Correct? How
yes.
is the voting pattern in a bank?
Higher shareholders get more votes.
So $1, one vote. Also, Anand has told based on contribution. What is it? It is $1, one vote. WHO is what? One country, one vote, irrespective of their contribution, which is equitable.
WHO. One country, one vote. Yeah.
Because it doesn't depend on your contribution. Fair enough? Yes. Now, what does $1, one vote signify? Okay, I'll make it a little simpler. What ism is $1, one vote?
Capitalism.
Capitalism. So let us have this in mind. The WHO is based on equity, WHO funding, while World Bank's funding is based on capital. Clear, all of you? Now let us come to historically. What is the geopolitical scenario in 1970s? How many of you are born? I don't know, but anyway, definitely Anands and Pravis were there. What is the geopolitical scenario in 1970? You understand the geopolitical scenario, no? What was the global order? What was happening in the world?
Cold War between USA.
Sorry?
Cold War between
Correct.
USA and
So Cold War between USA and USSR. In a way, it was a Cold War between capitalism and communism, socialism. Yes or no?
yes.
Yeah. 1970s also in the political economy has a very significant issue. That is, 1970s, there was a huge setback for welfare economics. Do we understand this? Welfare as in tax to GDP, the governments collect taxes and then give them. So welfare economics was not working globally in the 1970s. It had plateaued as in it had saturated, and then it was not leading to more gains. Okay, so these are the two major geopolitical factors confronting 1970s. So here comes Alma-Ata Declaration. And where is the declaration happening?
USSR, communist country.
Socialist communist country.
Socialist.
There is already a Cold War. Okay. And there is also a setback in terms of welfare economics. And then WHO comes up with a political declaration. Till then, it was a technical body advising on tuberculosis, malaria and all. And then the word in English is audacity. If people want to understand Hindi, jurrat. That's the word. I mean, fantastic words, both of them are. Anyway, so the WHO in this scenario came up with a political declaration. And let us, I crudely explain this in the way, don't mistake me. Let us see what are these 8 components of comprehensive primary health. In 1978, who was running nutrition programs? Who was responsible for nutrition population? Government or private or who? NGOs? NGOs are also private in a way. Sorry, Gayatri?
Private.
Government?
Water and sanitation. Yeah, sorry. The animation has gone berserk. Yeah, water and sanitation was also largely by governments. There was no Bisleri phenomena. If people, I'm not having mic today in the room, so I can make it more Indo-centric. Anyway, so education again was largely by government. Prevention of endemic diseases was by government. Mother and child was largely by government. Immunization was partly private, but mostly government. Treatment of ailments and injuries was also partly private, more government, and access to medicines was also like that. But in fact, access to medicines was more government than private at that time. Now, look at this scenario. I'm crudely explaining this, what I'm trying to tell you. What is Bisleri? Bisleri as in private water, Gayatri. That's why I told I'll be more Indo-centric today because Mike isn't around. Huh. Okay, so imagine welfare is going off, welfare economics is being questioned. WHO comes up with a declaration, and WHO holds the conference in a socialist country, comes up with a declaration which is all government, government, government. But who funds WHO maximum?
USA.
So here is an organization whose funding comes from capital, but its prescriptions are all social. So what would be the corollary of this? What would have happened because of this?
US would get angry.
And
And would decrease the funding of WHO.
stop the funding.
Stop.
So recent example is UNESCO recognized Palestine as an independent state. UNESCO, all of you understand. No? And again, US stopped the funding of UNESCO. And we think health is technical. Do we understand now? Okay, so here is an organization, sorry again, repeating, which had the audacity to come up with a political declaration emphasizing on the social nature of health, an organization which was only technical till then, making leaps into political arena. So Mary Billy, sorry, I think Mike has joined, but
Mujhe
anyway,
meow.
Mary Billy, mujhe hi,
Meow.
and thus was WHO brought to the knees. You understand, all of you? Bringing WHO to the knees. And then we also had something happened in 1977 in the global health scenario. What is it? What happened in 1977 vis-a-vis global health? Nah, all the younger ones
Was it
could not
AIDS,
answer. But sorry, was there
HIV,
any chat? No.
HIV? No.
81 में
No.
HIV हुआ था.
What happened in 1977 with respect to global health? Or it was not called global health that time. It was world health or whatever. Huh?
ORS.
The eradication of smallpox. Oh, sorry,
Okay.
somebody put it in chat. Walsh and Varam comes later, Anand. It was 82, 81. So here was a great example of a global health success of eradicating a disease. Now come back to the geopolitical scenario. Cold War, socialism and capitalism at war, WHO coming up with a political statement, welfare economics plateauing, and add one more global scenario or geopolitical scenario, there was an oil shock. Oil shock as in the petrol prices increasing. And that is when that was also the birth of neoliberalism. 79-80 was the birth of neoliberalism. So welfare economics had plateaued. So they said, no, this won't work. We need private property rights. We need lesser governments. And we need to move towards private property. Privatization, globalization, neoliberalism. All this confluenced together and then was added a shock of oil. They said, where is the money for this utopian idea of Almata? And this was health for all, not healthcare for all. It was health for all. It was about housing, water, sanitation, gender, every one of those. So where do we have money? We don't have money. Again, the scarcity bogey. And then Rockefeller Foundation, whom we might have all heard of, sponsored a conference in the 1980, I think 81 in Bellagio. It said,
Sorry, in where?
let us, Bellagio is a place in Italy. Rockefeller has a Bellagio Center for Global Health. Rockefeller, by the way, has always been into public health. That's a great thing. Or I don't know, it cuts both ways. Its public health programs have never been successful, except in South America. I mean, South of America, not South America. There are some southern states in America which achieved success with regard to hookworms, and in around 1930s. And that's when Rockefeller got excited and then said, let us do disease-based support and disease-based programs. So Rockefeller has always been at disease-based approaches to health. So they started hookworm program in Sri Lanka, hookworm program in India, pre-independence India. Everywhere it has been largely a failure. Because again, they did not take into consideration the larger socioeconomic conditions and the social nature of health. They wanted to have a magic bullet, like your current organizations of Bill and Melinda Gates Foundation and all. A magic bullet of, we discussed malaria, no, last time. Yeah, magic bullet of technocratic solutions for social problems. Anyway, so Rockefeller hosts a conference in 1980, prompted by World Bank, and two World Bank people write a paper. Their names are Walsh and Warren, which Anand mentioned. And they said, forget this utopian idea of health for all. We have the fantastic example of smallpox being eradicated. Let us go disease by disease. Are we getting? But smallpox was eradicated through a health systems approach, not a disease-based approach. That those logic and theory and all don't work for ideologies. Anyway, again, I'll combine all of them together. Cold War, socialism versus capitalism, US funding majorly United Nations, WHO making a political declaration, telling governments must be responsible. Then there was the slowing down of the welfare economics, neoliberalism, where governments were taboo. And then comes this prescription of what is called as selective primary healthcare. So from the comprehensive primary healthcare, which has social determinants and social nature of health, WHO slipped into what is called as selective primary healthcare. Not WHO. By the way, the fantastic thing was WHO and UNICEF co-hosted Almata. By the time 1980 happened, UNICEF had already left the boat. And then they were with the, so they brought in the first vertical program. So they said, let us tackle disease by disease by disease, forgetting that health is social and you need to take it comprehensively. So system approach was given a shortcut, and then they said, let us do it disease by disease. We have a fantastic example of smallpox. So we will tackle one by one, and thus was born the selective primary healthcare, what are also called as vertical programs. And that is the entry of World Bank into health. So WHO's funding was reduced or was brought down to its knees, and WHO was forced to get into disease-based programs to keep its head above water. And thus was born, for example, UNICEF started with something called as GOBI FFF, growth orientation, breastfeeding, immunization. FFF is family planning, female literacy, I don't know how it came into it, and fortification of food. So this GOBI triple F So one aberration was female literacy. I don't know where it came from, who got the brainwave that somewhere they had to include some social determinant, but largely it was about food fortification, family planning. We breed like rats. Malthusian economics, no? Food production is arithmetic, population is, logarithmic or exponential. So Malthusian economics influenced the World Bank. And in fact, one of the first World Bank's program has been on reproductive health. Not reproductive health, but more on family planning. RCH, what was called that time. Anyway, so World Bank enters the scene, says, I will give you money. WHO, you don't have money. But what is World Bank's ideology? $1, one vote. That is the capitalist ideology. And no talk of social determinants, nothing to do with equity, social justice and all. Take up one disease, we'll tackle one disease. And thus was World Bank brought into prominence in global health. Sorry, have I answered this question now? How did World Bank come into prominence in a global health scenario? And then World Bank in 1993 famously brought out its annual report called as Investing in Health. So the investment was investment in disease-based programs. And thus was born, the story of polio is a fantastic one. So I'll just run through this. I wanted to give you the evidence. That's why I just ran through this slide. So Rotary decides to fund some money. WHO doesn't have money. So Rotary goes to CDC Atlanta to decide which is the biggest public health problem of the world. And then CDC Atlanta comes up with the idea polio is the biggest one because we have stopped polio program in America, but Indians and others are coming to America. So they will bring polio and we will have to run that program. So let us tackle polio. Also low-hanging fruit, we will have fantastic results. And thus was born the Global Eradication of Polio Program, GEPI. What was it called? What was called as? And then you had tuberculosis, and then we had malaria. We had a series of vertical programs. And does anybody know what is the last count of the number of vertical programs in this country? Country as in mirror of the global one. Yes? Anybody? So it was 17 before NRHM tried to integrate all of them. But the integration hasn't been complete. So we are still thinking of diseases and we work as diseases. But yeah, so and World Bank in 1993 brought out what is called as investing in health. And thus World Bank became more prominent in global health than WHO. So WHO was merely again reduced to a technical body. In the meantime, Hafdan Mahler retired and there was another director general who came in who was also corrupt. There was efficiency issues, administrative problems and all. So all of them combined and completely undermined and killed the Alma Ata idea. Sorry, does this answer the question? Since many of you had asked this question and that was the starting point for this dialogue.
Yes.
In a way. So this fascination with technology, with private sector, I thought is a good prelude for me to start talking about the private sector. Some of you might be working in private sector. Again, a disclaimer. I'm just going to present to you all the concepts as they are. And then also the evidence is there. I will share the evidence subsequently as to where we are vis-a-vis the great engagement with the private sector. Sorry. This just to complete it. 1980s. neoliberalism and market logic. Yeah. So if any of you still had doubts about health being a technical activity, you can be rest assured health is out and out a political game. Yes? Clear? Okay. So let us start the private sector. Anybody wants to name the types of private we have? Keep the buzzer on, keep it going. Either chat or who is this?
Corporate hospitals.
Okay. One.
And small private nursing homes.
Okay.
Rural medical
You're still in
practice.
the top of the... Okay, you people are still in the top of the pile.
Private insurance companies.
Rural medical practice.
Okay.
Then traditional healers.
Okay, Ram Kishore, private clinics, and that is single doctor clinics, dispensaries, whatever. Then
NGOs are not government sector, so
shouldn't matter. Yeah, non-governmental sector. Okay, I won't say it private, non-government.
Even pharmacies.
Okay, let me run through the list. And this is still not exhaustive, by the way. Anyway, so just to give a flavor of what the private sector means. So you cannot deal with private sector as one single entity. That was what I wanted to. Yeah, now you have pharmacies, you have online consultations, you have franchises, you have many more types of private people. Anyway, sorry, just to come back to Anand's question, how did World Bank influence UNICEF and WHO? Yeah, that's what I was telling you, Anand, that because WHO was starved of funds, WHO had to depend on other sources of funds. And then at that time, philanthropy was big thing because anyway, health as a global phenomena did not have enough funds. So WHO then had to listen to the funders, so to say. So the Rockefellers and World Banks then dictated. And to some extent, if you were to look at the Rotary scenario, Rotary story, the Rotary people initiated the polio initiative. So they went to CDC, and then that's how the medical establishments dominated the health dial and debate. Yeah, so sorry, Anand, have I answered? Yeah, thanks. Okay, so this is the nature of the private sector. So it is not one single elephant. It is a nuanced or multi-layered sort of private. So what are we as a nation are generally, excusing again, Mike, we are what is called as, what is coined as mixed health system syndrome. Generally, all health systems are mixed health systems, wherein private sector operates side by side with the centrally planned public health sector. Okay, so we are all countries have some sort of a mixed health system, except maybe some country like Cuba. Even there is a little bit of private sector, but largely it's public sector. Yeah. So we are all in varied degrees of mixed health systems, but there are specific characteristics of low and middle income countries like India. They are heterogeneity and diversity of providers. As you saw, no? It could be traditional, non-traditional, trained, untrained, all sorts of people. So there is heterogeneity and diversity of providers. Weak public health services. This is more LMIC, not high income countries. Chronic under investment in public health systems. So historically, we have never invested in public health systems. Lack of staff and infrastructure, and poor quality of service delivery. Yeah, fragmented, I'll come to fragmentation. So what does it result in? Yeah, the economists or the health economists call this poorly organized private markets. Organized private market is in the sense of regulation, bringing them under one umbrella, or making it a universal system. So that is an organized private market. But LMICs are anything but that. Highly unregulated, inequitable, high out-of-pocket payments, which all of us understand, no experience. Most of the care is in the private sector. And on top of it, there is the blurring of boundaries between who is public and who is private. So, public personnel moonlighting, that is public system people running their own private clinics or being in corporate hospitals and all those things. We have private providers contracted in. For example, there are some specialists who have been contracted in. If you are a retired obstetricist, OBG surgeon, then you might be brought in, contracted into the public health system. All these result in unnecessary high costs of care, variable, often poor quality of care, unethical conduct of the providers, and outright non-availability of care. And all these together was coined as a mixed health systems syndrome. It's a disease in itself in LMICs, what Nishtar has famously commented. Yes, Sayantan, go ahead.
Am I audible?
Luckily, I saw your raising of hands. Yeah.
No, sorry, I'm traveling, so there might be some noise. No, so my question is, unnecessarily high cost of care, is this also driven by the medical industrial complex where profit making is also a driving factor? Does it also fit into this scheme?
That is why we call it highly unregulated. Yeah. If you don't have regulation.
Okay, in that way. Okay, got it.
Yeah. Regulation means also cost of care and quality of care. So it's not just quality of care in some sense. Yeah. Clear, all of you? So Nishtar classifies this as a disease itself, as a mixed health systems syndrome that we all in LMICs have. Sania Nishtar is from Pakistan. She is a researcher.
Prasanna, one question, please.
Yes.
Sorry. I just want to know how is, when you say that contractual healthcare workers leads to increase unnecessarily high costs of care. How does that work out? Can you please explain?
No. What I'm talking is the blurring of the boundaries. That is, the dichotomy is not there anymore. Who is public, who is private is very hard to decipher. And that is also the reason why cost of care can go up. For example, the one who is moonlighting, okay, can say, no, I won't treat you here, come to my clinic. That is one way. Okay, so there people will incur costs. The contracted in people might also demand. I'll come to that. Just hold on to your question. I need to explain some of the other phenomena. But the contracted in people can, for example, demand their share of the pie in some sense, and then say, because they know that the government is in a weaker position, and then they can demand much higher prices. Those sorts of things. Yeah. So what are the ostensible reasons why there is still this enthusiasm about engaging the private sector? So some of the reasons I just wanted to outline and then get into some of the theories around it. One is, of course, the efficiency argument. We have all seen how market theory says competition needs to be there and efficiency has to be gained using the market route. So this is a clear one which we have talked about at length in the previous sessions. Poor quality of services by the public sector, definitely, we all agree, public sector performance has been very bad, and the non-responsiveness of the public sector and those sorts of things. Yeah, I don't know, Prabir, you might have to ask the others. Are all of you able to hear?
Yes.
Are you able to hear me properly?
Yes.
Okay. Prabir, maybe you will have to raise your volume. And the third reason is majority of services are anyway provided by private. Why don't we harness? So as we keep on telling, 60% of the OPD is by private. Hardly what you call 20% of the inpatient is by public. I mean, all this we keep on telling that anyways people are going to private. Why don't we harness the private sector services? And this was also officially put into a policy, the National Health Policy of 2017, telling that we should harness the capacities that are available in the private sector. And the last one is the budgetary constraint. I'll not explain this just now. I'll come back to this a little later. So sorry, now all of you, I will be getting into some concepts, and these are really economic concepts, need to be a little more, what you call, focused or attentive, whatever. So there is something called as make or buy decisions. So for example, let us say you are running a college. Anybody is running a college. All the students have to come to the college. So either you can buy a bus, for example, a big bus or 10 buses, whatever, maintain those buses, pay the drivers, pay for the petrol, all of those, and then get all the students at one time into the college. That is one way to do it. That is what is called as making. All of you with me? Please raise your hands if you don't understand anything. Then there is a buy decision. Buy as in, no, why should I get into the headache? One driver will call me at 4 o'clock in the morning telling that my bus has broken down, or petrol is not there, or tire has got punctured, or the driver goes on leave and then I'll have to arrange another driver. I don't want any of these headaches. I will buy it. That is, I will give a contract to some travel agency and then they will run the show for me. All of you are clear now? What is a make and what is a buy? Any questions here?
Yeah.
I can go a little slow. Yeah. Yes, Gayatri.
No, I meant you can go ahead. No questions.
Acha, that way. Okay. So similarly in healthcare also we have what is called as make or buy decisions. Supposing I have a hospital. So should I buy canteen services or should I make canteen services? Should I make laundry services or should I buy laundry services? All of you are with me? Should I make clinical care or should I buy clinical care? Is this clear scenario? So I can make a canteen, that is, I as a hospital administration will open a canteen, will take care of the vegetables to be bought, the meat that has to be bought, the stove that has to be run, the fuel that it needs, whatever, gas that it needs, and all those things. I will do everything of this to run the canteen. I will also hire the cooks and those sorts of things. Similarly, the laundry. I will buy those washing machines or whatever, and then I will run the laundry myself. That is making. Then you have what are called as buy decisions. I say, no headache for me. I'll just contract it out to some caterer. I'll contract it out to some launderer. Am I clear?
Yep.
Now the decision making has to be done. When will you buy and when will you make? For which there is economic theory and institutional economics, which gives you a fantastic matrix, what is called as measurability and contestability matrix. Sorry, you'll have to give a little bit more attention on this. Measurability is the ability to measure the services delivered. That is, for example, I have given the healthcare example. If you take laundry, the number of linen that has to be cleaned, or number of food thalis or plates that you have to deliver in a day. So those are the measurability matrix. Then the contestability matrix comes in. Contestability is the ease with which you can enter or exit the market, for which I'll have to explain to you a concept called as Just I'll come to that. Ah, shucks. Did I lose it? Something called as, sorry, I'm jumping it. I'll come back to that previous slide. Something called as high asset specificity. Sorry, all of you, please understand this. If I have to run, if I have to, for example, buy pens, or I'm a manufacturer of pen as in stationary pen, then whether I supply it to the hospital or I supply it to the hotel or I supply it to the college, it doesn't matter. The asset is not very specific for the service I am delivering. All of you with me? Somebody say yes or no, please. These are very tough.
Yes,
I'm
so
trying
far.
to simplify.
So far. Yeah.
Sorry, Gayatri, I'm hoping you are the spokesperson for the group anyway. So the asset specificity is how specific is the asset that I am creating for delivering that service. For example, if I am a pen manufacturer, or let us say I am a syringe manufacturer, then whether I supply to the hospital, the clinic, nursing home or wherever, or to the pharmacist, I don't have specificity of the asset that I am creating. The machine is the same everywhere. Supposing I am into cleaning the streets of the city, I need to buy those big lorries. I don't know whether you people know those big lorries with vacuum cleaners and all. Then you try to become a little bit more asset specific. Supposing I had to run a CT scan service, then my specificity increases. Yes or no? The CT
Yes.
scan cannot be put in hotel. The CT scan cannot be put in. So this is the higher the asset specificities, the tougher it is to have contracts. I'll come to that. So your entry and exit of the market is very tough. Once you enter into the market as a CT scan specialist, you cannot exit it easily in the sense of a pen manufacturer. The pen manufacturer, he can enter into hospital, exit hospital, he can enter into hotel, exit the hotel. All of you are understanding now what it means?
Prasanna, I have a question. So if I were
Mhm.
to look at it from the perspective of the public procurer, high asset specificity would be attributed to, let's say, a digital hemoglobinometer versus consumables.
Correct.
Yeah.
Or even laundry or even canteen services, for example. Clear? All of you? And
Prasanna,
that is the contested.
one question, please. When you say it's difficult to exit the market, what do you mean?
That is, I cannot, for example, establish a CT scan machine and then say I'm exiting this market and do something else. I've already committed my resources and then there is asset specificity. Whereas a pen manufacturer can say, yeah, hell with this hospital, I'll go to another hospital, I'll go to hotel, I'll go to some college. High investment cost is a good simple word. Science and thanks. Yeah. Not only cost per se, but also technology, also many other factors. So
Yeah.
the asset is very specific to the delivery of the service. All of you with me? Supposing, say, let us decrease the level of asset specificity in terms of ambulance. What does it mean? Ambulance, whether I deploy it to the district hospital or I deploy it to the private fellow or I run my own ambulance, it's easy. Yes or no? Even though ambulance is slightly more asset specific than pen. So the gradient is like that. Pens, canteens, laundries, ambulance, medicines, and clinical care. Am I giving you the gradient? Am I giving you the spectrum?
Yeah.
Yes. So the institutional economics provides us. Sorry, it's not going back. With what is called as contestability and measurability matrix. The higher the measurability and contestability, the easier it is for entry and exit. You can measure specifically how many pens you are buying, how much of syringes you are buying, for example. You can measure numbers, yes?
Yeah.
While at the same time, it's also contestable in the sense that the syringe that can be deployed in this hospital can be taken away and then given to the public health system or wherever it is. Similar is pens. We all understand pens and okay. Similar is also the issue of non-clinical activities like laundry, canteen and all. Okay. Wherein measurability is a little tough, but it is still very highly contestable. Whether I put a canteen in a hotel, whether I put a canteen in a hostel, or whether I put a canteen in hospital, it doesn't matter. There is no specificities. There are no specificities associated with it. Clear? Now, as you move to the right in the matrix, it becomes tougher and tougher and tougher. All of you with me? Measurability as it becomes tougher, contestability as it becomes tougher, it is going to be that much more highly asset specific. Am I okay till now? Any questions? Yeah, for those of you who are traveling or accessing it on mobile, some of the medium contestability aspects would be wholesale distribution of drugs. Of course, there is some specificity involved in not drug manufacturing, by the way. This is drug distribution. So whether I distribute it to the hospital or to the nursing home or to the public system, it doesn't matter to me. But at the same time, there is reasonable amount of measurability. Contestability, there is a little problem in the sense that I need to have a pharmacy degree and those sorts of things. So that way it becomes a little bit more asset specific, but measurability is always very high. Who is this? Any question here? Yeah. Okay. So next is what are the, as you go right, like for example, public health services, how do you measure? How do you measure dengue control achieved through sanitation? It's very low measurability. You cannot say I stopped 10 dengue cases because of this sanitation. And similarly, for low contestability, you have policy making, which is both low contestable and low measurable. You cannot say that I did this policy and then I achieved this. It's very tough. And similar is the higher education, medical education.
திரும்ப
all
இதை
of
அப்படியே
those.
ஷூட் பண்ணலாமா? திரும்ப இதை அப்படியே ஷூட் பண்ணிக்கலாமா?
Somebody is unmuted. So as you move across the matrix, the measurability and contestability decreases. And this has huge implication for make or buy. All of you with me? The more contestable and more measurable something is, the more you can contract out. You can buy. So you can buy, for example, you don't need to start making stationery if you want to run a hospital. You don't need to start manufacturing pens and those sorts of things. Clear, all of you? While definitely, if you are into hospital, your research or higher education definitely is a make scenario. Can somebody give me the confidence that this is okay?
No, can you please repeat the last thing, please?
So
Just the last
supposing
bit.
you're into a hospital, wherein you have, for example, high-end cancer treatment and all, you cannot do it as a buy phenomenon because it has high asset specificity in terms of training, in terms of research, in terms of all of this.
Right. Got it.
Yeah. So
Yeah.
then you are better off making it rather than buying it because you cannot measure it as to how, whether you had to do this CT scan or whether you had to do this MRI, or you can never attribute it because anybody can come back to you and then say, no, I wanted to be safe. So I did this X-ray, or I did this MRI, or I did this hysterectomy, or I did this C-section delivery. Am I making sense
Yes.
now? When do
Yes.
you make and when do you buy? And this is the whole game of engaging with private sector. When can you engage private sector? I mean, I'm still talking economic terms. Please bear with me. I'm still giving you the economic concepts. Okay. Even though I'm relating it to the healthcare industry. So this matrix makes it very clear when you can buy, when you can do contracting and regulations, when you have to compulsorily make it. Of course, you can shift this way, that way a little, but largely the bottommost two rows or bottommost two sections, invariably you have to do making. Am I clear?
Yeah.
And now I come into the middle portion. When can you write complete contracts? You can only write complete contracts when there is a reasonable amount of measurability and reasonable amount of contestability. And that is the whole game of the private sector engagement. When can you write a full contract for delivery services? Anybody? All your Chiranjeevi schemes and all your Janani Sahyogi Yojana, any of those, can you write a full contract telling that this is the standard treatment guideline, this is what it is, and you will be given money for these services? Can we write a full contract? Why, Ravi? Why can't you write a full contract?
Yeah, because there's so much variation in the guidelines and there's so much subjectivity also. There's a lot of experience that comes in. So you
No,
can
from
easily
this
justify
matrix,
doing it.
with respect to this matrix,
Okay.
can you explain?
The measurability is low.
Yeah.
Yes. Also, contestability is low. If you have only specific OBG people with highly asset specific characteristics to deliver the services, then invariably you cannot demand quote unquote performance.
Yeah.
You will, and also because of low measurability, that person can come back and then say, no, it was a very critical case and I had to do C-section. Will you say why, how, what? No way you can write full contracts. Am I making sense now? So the higher the asset specificity, the lower is the complete contract scenario. Whereas in the case of pens, medicines also, you can largely say, okay, I am asking you for 10 packets of paracetamol. I'm going to measure 10 packets of paracetamol. And then the paracetamol fellow can also exit and enter and there is no asset specificity. That is easy to buy. And also to write full contracts. But when it comes to clinical services, when it comes to other aspects, particularly determinants, there is no way. One is you cannot measure. Second is asset specificity is very high. Clear scenario when you can engage private sector under what
It
conditions?
also applies to insurance then, right?
Yes. I'm talking about healthcare scenario largely.
Right.
Even insurance people cannot write full contract. And that's also the whole issue of co-payments and which gets rejected, what gets accepted. I mean, they do lots of circus. I mean, sorry to use the word, but trying to cut here, cut there, and then say, no, hospitals, you have to fall in line. You have to not have so much of consumable, so to say. But then invariably, the hospitals can justify telling that, no, these were the consumables needed. This was what was the X-ray needed, ECG needed. Are you getting what I'm telling? So writing complete contracts is next to impossible for clinical service. Yes? With me, all of you? Where are we
Yes.
with time?
It's 7:40.
Oh, I'm doing good. Not bad for once. So you understood this. Higher the asset specificity, tougher it is to write contracts. The next question is this. Sorry. Now come back to healthcare. Healthcare, Anand, just hold back. please come back to me with this question a little later. Are there clinical services which can be contracted? We'll come to it. I just want to complete this concept and then give you specific examples. Ex ante competition. So now get back to the theory that health is a market failure. All of you clear? You cannot have market theory in health. So under perfect markets, sorry, none of it is taught to any of the health professionals, be it medicine or wherever. And that's why I take extra efforts to demystify some of this. So, but economists are wanting to bring in efficiency. We all understood that. There is scarcity, so you need to have decision-making tools. And one of the decision-making tools is to get efficiency. But when it is a market failure, efficiency cannot be had from competition within the market. Sorry, hold on. Competition within the market means, oh, I don't have the pens with me. Okay, all of you will have to imagine the pen example that I kept giving, no? Last session. Let me see if I can get hold of some pens. One pen. Huh. At least I have to. Okay. So competition within the market is that I am competing with the pen fellow. So when it is a perfect competition and contestability is very high, competition can happen within the markets. That is competition between Reynolds and Cello and all of those can happen. Okay. Now, health is a market failure. That is, competition within the market is not possible because it is a monopolistic tendency. Now, then how do we achieve efficiency? So they say, instead of competition within the market, you need to have competition for the market. Sorry, are you understanding? Instead of Cello, Reynolds, whatever, Flair, whatever competing with each other, all of them will compete for the market. For example, you cannot have side by side Apollo, or let us take the example of roads. Road is also a market failure. Okay, so you cannot have one road of L&T, one road of GMR, another road of some other provider, and then say compete with each other. Whoever gives the best road services between Bangalore and Delhi, you can avail it. That's not possible, no? Like how you use for car or pens or whatever. You cannot have 3 parallel roads from Bangalore to Delhi and then say, no, whoever gives the best road, people will use it and the other will fall off the competition. That's not possible. So what you do is you make L&T, GMR and all compete for that one road and then you can gain efficiency.
Are these what are called natural monopolies?
Sorry?
These called natural monopolies.
Yeah, natural monopolies are those which are market failures.
Oh, thanks.
Okay. So this is called as ex ante, that is competition before the breeding process. There is ex post, that is what this is. This is ex post, while that is ex ante. That is, you cannot have Apollo, Fortis, Wockhardt, whosoever competing amongst each other for the set of services, but you make them compete for one service. So there is not possible of competition within, but competition for. Clear? Where there is market failure. Again, I'm still at the economic concepts. Please, pardon me for that. Ex post is competition after the award of contract. That is your classic scenario wherein you try and get the competition between the suppliers. Supposing some supplier is giving you paracetamol at one carton of paracetamol at 100 rupees, another is trying to give you. That's what Tamil Nadu Medical Services Corporation does. public procurement is based on competition after the award of contract. Clear, all of you? Ex post and ex ante. Yes, somebody give me the confidence.
No,
Like
so
I'm seeing one of your question. I'll just come back to you on that. Huh?
yeah, Prasanna, I think I have a little bit of confusion. You're saying that
Mhm.
ex post competition is that they are awarded the contract and then there is competition?
They are made to bid
Yeah,
as a tender. They are made to bid for a service.
but ex ante,
Whereas there
how
is,
do, yeah, how,
yeah, ex ante is that before. Anything ante, like you have antenatal services,
yeah.
no, it is before. Huh? Then
So how,
postnatal, ex post. Huh?
so in that situation, how does it, when you say competition before the bidding process,
Huh?
how is the competition decided? On what basis? Did they
On
bid
the
a,
basis of lowest price, yeah, that's the efficiency, no? L1 bid, as they call, lowest price for the same provision of services or more provision of services for the same amount, I mean, same money, like that. As it happens with the tender. Regular tender services that happen, no?
yeah, okay.
Sorry. Did you understand what I'm talking about?
Yeah.
The regular tender is you call for a specific performance and then say, give you a price. So there will be some technical bid and there will be a financial bid. So the technical bid will match the performances that are required. And then the financial one tells you the money that they need.
Right.
Okay. So whoever is L1, the lowest bidder for the performances or the bidder with the highest number of, I mean, for the same money, more number of services, that person will get the contract. That's the bidding.
Yeah.
Yes.
So this is
All of
ex
you with
ante.
me? Ex ante. Ex
Right.
post is supposing you are having already a contract with somebody, then you can also, for example, pen manufacturer, you can say, okay, you are giving me at this price. I will ask somebody else also to give me at this price, even after the award of contract. Even that is possible. And
Okay.
then drag this fellow down. Even that is possible. No?
Got it.
Competition in the market is competition. I mean, competition in the market for the market. I have already explained. Clear, all of you now? Now, given this scenario, let us talk about private engagement in health. Mike, your question is too big to be answered now. Anyway, let us see. And here is a fantastic framework for, I think I should come back to this a little later. I'll just, okay, so contracting in, private providers are contracted into public health system. Contracting out, they're contracted out to the private sector. For example, you have some gynecologists who retired were contracted in, and contracted out is the government contracts out certain services to private sector. It could be your Chiranjeevi scheme, or it could be your Ayushman Bharat, it could be running of PHC that was done by Karnataka government or many other state governments. But does contracting mean privatization?
Not necessarily,
Question.
because the accountability still lies with the public service provider.
Yes. Not accountability. Again, economic term, assets are still owned by the government. Okay, so it is not exactly a complete privatization. The privatization would be, for example, handing over the public sector units to private sector. That is disinvestment and then handing it over, and government has nothing. Air India is a classic example. Air India, how they really privatized it, is the classic example of privatization, wherein the government doesn't have any assets, doesn't have any stake in it, and those sorts of things. Okay. But for contracting, Liu Hotchkiss and Bose, they give a fantastic framework telling that people are very happy with one or two parameters. Like, for example, any evaluation of any contracting services, and the literature is full of that one, they only measure any one of these parameters, either access or efficiency, maybe equity nowhere comes in, but anyway, and then quality. So none of them evaluate on all these four parameters. Either they're happy just saying, oh, the access has increased. For example, the whole issue of the government contracting out the primary health services. Okay, so the fantastic argument is yes, access has been fantastic, but what is the quality? Where is the efficiency? So if you don't measure or evaluate any of the contracting services against all these 4 parameters, then you are not evaluating properly the contracting out. Am I clear? So next time onward, somebody romantically tells you, oh yeah, see how fantastically the efficiency has improved. The government had to spend so much money, but the private sector is doing it such less. But you can ask, where is the equity aspect? Where is the access? What is the quality? So you can keep questioning. So these are the parameters. This is a very good framework for analyzing any contracting service. Am I clear? Yes or no?
Yes. Yes.
Okay, now let us come to the great topic. Public-private partnerships. Okay, so I'll give you 6 examples. I'll keep running through them. I would be happy if somebody read these cases. Whoever is not on mobile or something.
Should I read
Yes.
them loud?
Yes, please. All of you, please give attention. Huh?
National Highways Authority of India, NHAI, wants to construct the airport road between New Airport in Bangalore and Hebbal. A tender is called and private players like L&T, GMR and Navyuga Constructions bid for it. Navyuga Constructions wins the bid, finances it and then constructs the 6-lane airport road and is given the permission to collect toll for the next 20 years.
First case. Second one, can somebody read? Somebody else. Hello? No volunteers? I'm not able to see. Anybody unmuting?
I am
Go ahead. Quickly.
Karnataka state government decides to construct a 4-lane Bangalore-Mysore highway. It calls for tenders from construction players. L&T, GMR and Navyuga Constructions bid for it and L&T wins the contract. The 4-lane is constructed and the government pays L&T the tender amount after completion.
Both these scenarios, all of you understood? Yes?
Yes.
Yes, please. Whoever.
Karnataka government wants to construct a hospital and invites tenders from private construction players to construct the hospital, and the lowest bidder gets the contract to construct the hospital.
Fourth one.
Karnataka government contracts out primary health center to NGOs and medical colleges. Ritika, do you want to read this, please?
Sure. Karnataka government constructs a hospital in Raichur, Rajiv Gandhi Super Specialty Hospital, also called an OPEC hospital, from the funds received from OPEC countries. After construction, it hands over the running of the hospital to Apollo Hospital for 10 years with the understanding that Apollo shall provide free services for BPL population.
Yes, please.
Read off, Ritika. No.
Braun Company negotiates with the Andhra Pradesh government for installing dialysis units in the government hospital premises and shall charge user fees to the patients. BPL families treatment is reimbursed by the government/RKS.
RKS is Rogi Kalyan Samiti. Anyway. So these are the 6 quote unquote public-private partnerships. Are all these public-private partnerships? All of you understood the scenarios, no? One is National Highway Authority giving construction contract to Navyuga. Navyuga bids, finances it and constructs the airport road and then collects toll. Karnataka state government also constructs a Bangalore-Mysore highway but calls for a tender and then government pays the tender the amount. The winner the amount. Then Karnataka constructs a hospital and then invites tenders to construct the hospital, and then the lowest bidder gets the contract and gets paid by the government. Karnataka government hands out and contracts out primary health centers to NGOs and medical colleges. That's the fourth one. Fifth one is Karnataka government constructs a hospital and hands it over to Apollo for running it for 10 years. And with the promise that Apollo will provide free services. And sixth one is Brown negotiates with Andhra Pradesh for installing dialysis units. And now I read that it is there in about 15 states and shall charge user fees for the patients. BPL families will be reimbursed by the Rogi Kalyan Samiti of the government. Yes. Now, which one of these are public-private partnerships and which ones aren't? Are all of these public-private partnerships?
I feel like all of them are public-private partnerships, but with differing amounts of public and private.
Okay. How many with Gayatri? I'll just remove
I
this.
think 5 and 6 are public-private partnerships.
Okay. So some are saying 5 and 6 are, some are saying all are. So should we do a raise of hands? How do I do that? How do I see it?
I agree with Gayatri. Kranti.
Sorry?
I agree with Kranti.
But
They're all private, public-private partnerships in varying degree.
Okay. Anyone else? Anyone else wants to hazard a guess?
Some
Quickly.
seem to be contracting in and some seem to be contracting out. Particularly
That's okay. Are they public-private partnerships? We have moved on from contracting in and out.
They all could be public-private interactions, whether they're partnerships or one is just servicing somebody else, I don't know.
Okay, so let us get to the definitions of what is this nonsense called as public-private partnership and what is the ideology of this. Okay, so I'll just come back to these 6 case studies again after giving you the exact definition of what it is. Okay, so there has to be 4 conditionalities to be what you call adhere to in order to be called a true PPP. One is it must serve a public service, which is a market failure, such as health, water, roads. Clear? A long-term contract must exist between the public and the private entity. Most importantly, the private entity owns and finances assets to produce and supply services. Now tell me how many of those are PPPs? The private entity should own, finance, and produce and supply services. And there must be optical allocation and transfer of risks. Now tell me which one of these adhere to these 4 conditions.
so the road that was made and the toll was also collected by L&T, that was a public-private partnership.
Sorry, I lost the track of the slides. Yes. Then, which else? Okay. The romance and the nonsense, sorry to use the word nonsense, of public-private partnership lies in this conflation of anything that is between public and private as public-private partnership. The partnership has a definite connotation. What does partnership, what is the feeling that evokes when we talk about partnership? What is the feeling? When you say partnership, what do you feel? Sorry?
Some solidarity.
Hugging.
Yeah.
No, I'm asking feeling, not the brain. Hugging, no? But can a public and private hug each other? One is a regulator, the other is a regulatee.
Yeah.
You cannot have a partnership between public and private for the simple reason that there is a goal conflict. The goal of private is what? Even if it
profit.
is non-profit, what is the goal of private? Profit.
Efficiency.
Whether it is
Yeah.
goodwill or
Profit.
whether it is whatever. Private. Yeah, profit, no? Private
Profit.
sector. What is the goal of public sector?
Welfare.
Welfare.
Welfare, accountability, responsiveness. Why should the private sector be accountable, be responsive, be what you call service oriented? What talks in private sector? Money talks. So there's a fundamental goal conflict by telling that public and private are going to hug each other in the sense of partnership. There is a huge power differential of a regulator and a regulatee. There should be that power differential. And you cannot conflate it. So Mike is telling on that score, none of them are partnerships. Actually, the first one is the only one which is that, what is called as the boot concept. How many of you have heard of the boot? Prabir came a little near, but he couldn't go further on this. So either it is boot or bot or those ones. So in which the risks are also with the private sector. Supposing there is a change of government and a change of intention, the private sector has to take the political risk on itself. Financing. Supposing the company goes bankrupt while executing the project, that has to be taken by the company. Now tell me which one has the financial risk covered in the other 5? Nowhere. Tell me where is the political risk involved in the other 4, in the other 5? Nowhere. Where is the asset? Who has produced the asset for the delivery of the services? Except the first one, no one else. Second one also in a sense, but yeah, but the government has paid for. And another thing to bear in mind is public. Sorry, I might be very loud at 11:40. Maybe I've got a warning. Just a minute. Sorry. 2 minutes. In my excitement, I forgot that I was in Japan and okay, so now I'll try to tone down. The risk of the 4-lane highway between Bangalore and Mysore was with the government and not with the provider. Here, the assets are not created by the private fellow for it to be called a public-private partnership. And public and private have always interacted. For example, even if the government has to construct a hospital, it doesn't get into the business of pebbles, sand, cement and all. It will still call the private fellows. So this any public-private interaction passed off as public-private partnership is a neoliberal construct. And the whole concept of partnership is, as they say in English, humbug.
So Prasanna, you're saying that though the word used here is partnerships, it actually means something else according to the definition. It's not a partnership in
Okay, so the
how we think of
origin,
the word.
so the origins of this public-private partnership was, I mean, the coining of this term for a public-private interaction. The public and private have always interacted. Am I clear? The only difference is Margaret Thatcher in the UK brought in what is called as private finance initiative, which she coined it as public-private partnership. So there is private, which is efficient, and there is public, which is not efficient. And so let us have a partnership in the sense of private finance initiative, PFI, they're called as. Okay. And the reason for that is, sorry. Okay. Can I ask a question? Who is unmuted? Who is unmuted? Let me see. Anybody unmuted? Except Gayatri, anybody else? Okay. So, okay, it's a good question to Gayatri also. So let us say, Gayatri, you want to buy a high-end television. 4K, whatever. You know those televisions, no, that come. Smart 4K TVs, televisions. So what is the cost of that?
I'm just saying one random number, 25,000.
Hello? You're nowhere, madam. Televisions cost you 1.22, anywhere between 1.2 and 4 lakhs. Okay. So if it is 1.5 lakhs, will you jump at the drop of the hat and then say, no, I'm very impressed with this television, I'll go and buy?
No, I'll do my research.
Even then, let us say you are taken in completely by this and then say, I will shell in 1.5 lakhs and then buy the television and come. Will you?
I mean, I wouldn't.
Okay. Stay there. Stay there. Supposing I say, you can pay me 1.5 lakhs over 3 years at an installment of 3,000 rupees per month. Are you in?
It depends on how badly I want the TV.
Fair enough. You have made the decision to buy. When will you buy? Whether you will buy when it is upfront payment or whether will you buy when it is EMI or installments to help my.
It's easier for me to buy it in installments.
That was the logic Margaret Thatcher brought in. And the logic was, if I spend 20, for example, 20 billion, let us say 3 billion on a hospital construction this year and show it in my budget, I will show higher deficit. So what I will do, I will put it to private finance. The private will construct over 20 years. And then I will get a bill of only 10 million pounds per year in my budget. And then my budget will look very rosy. I won't be able to show fiscal deficits. Are we understanding this? On top of it, of course, the sorry. Yes?
No, please go ahead.
On top of it, you have the neoliberal idea that governments are monolithic, inefficient, non-performing entities. So what Margaret Thatcher did is, it's called the sleight of hand in English. Sleight of hand is do what you call jugglery in the numbers. And then she said, no, I'll call this public-private partnership. It's a partnership. Private is efficient. Public is bad. And on top of it, I had to show fiscal deficits. If it is a 3 billion pound 1 year shown in that budget, then it will show so much of expenditure. Mind you, healthcare is expenditure and tobacco is income. So in that scenario, Margaret Thatcher said, no, let us do private finance initiative. I will hand it over to private. Private will construct. Private will run. Private will then hand it over to me after 20 years when I would have paid the installments over 20 years. But ignoring the 0% 0% financing that you see these days, has any EMI been cost effective? Are EMIs cost effective?
No.
Why not, Mike? You're going against Thatcher.
Yeah, good. because well, I mean, I don't know, but people say that we could have had 3 hospitals for the price of 1 if we hadn't gone for
Yes,
PFI.
that's exactly the evidence that was presented. Neither was it cost efficient, nor was it service efficient, because there is something in finances and economics called as net present value. A bird in the hand is worth 2 in the bush. So if the money you have today is more worthy than the money you will have 3 years later. So even though, let us say you have a 0% interest on your installments, even then you would have paid that much more money at the end of the 3 years, because your net present value is higher than what the money will be 3 years later. All of you with me?
Yeah. Can I ask a question?
Yes, please.
If we have
You don't need to
already,
be polite. You can just say a question. Finish. Don't waste time. Huh?
if we have already seen a study which is saying that these partnerships in courts do not actually mean partnerships, and that in the long run it doesn't actually show any benefit, why do our policymakers still pushing for an increased in these partnerships, especially in something like primary healthcare? We already know it's a failed dynamic.
Yes. Do we all not know? Did we not narrate the Fair and Lovely phenomenon? Don't we all know Fair and Lovely doesn't make anybody
Fair or lovely?
fairer? It's the ideology. It's just plain ideology that governments are bad, governments are inefficient, and governments have no business to be in the business and the romance with the private sector. Am I clear? Yes, Ritika, I'm just coming to that. Where were we? Here, no? No, next. So now, henceforth, at least the 18 of you are still in the room, or 19 of you, please do not use the word public-private partnership loosely. Don't allow for the jappi, the hugging, to be romanticized. None of them are PPPs except the highways. And there also I can question as to why one has to pay twice for the same services. If you have already paid the road taxes, why do you have to pay the toll again? Am I clear? Yes or no? Okay,
Yes.
even understanding from World Bank's perspective, let us see what it says. A PPP is a long-term contract between a private and a government entity. Remember, it's a long-term contract. It should provide a public asset. It should result in an asset. And the private party bears significant risks. And the remuneration is linked to performance. Even World Bank is telling this. Forget Walila. Despite this, World Bank actively promotes, and of course, this all started with Kofi Annan being the UN Secretary General. When he was there, he proposed a public-private partnership for all the services. He said, Coca-Cola reaches every village, but FAO cannot deliver food grains to all the villages. So let us have a public-private partnership between Coca-Cola and FAO. Are we seeing the goal conflict here? the ideology, and the lack of evidence. Am I clear? So please, henceforth, that's why we stopped calling all of this as public-private partnerships. We say public-private interactions. Yes? And there are dime a dozen listed out. Latest paper by Nandi and Baru show the list of PPPs. So that is marketing gimmick we are. Mac buns to be made of wheat. But to tell that the biggest public-private partnership was between, by the way, since VR is mentioning about Mac. So McDonald's wanted to have a tie-up with WHO. So for each McDonald's sold, McDonald's would have would provide WHO with $5 or something. So then the public-private partnership would be completely organic, full-fledged hugging between the public institution and the private. Anyway, so it was shelved after public outcry and all, but we have seen many more of those versions through many more institutions. Anyway, so I listed this out. I'll share this anyway, PowerPoint with all of you. Some of them are here, not all of them are here, but largely there is zero evidence that PPPs have delivered. And that too, again, you have to measure it against these four things. Any PPP has to be measured against these four. They don't measure up. So there are about 17 public-private partnerships listed. I'll share that paper with all of you. None of them in India. Of course, in the UK, PFI has been rubbished long back. None of the PPPs in India have delivered. And the classic case was, there are 2-3 classic cases in India when it comes to the great public-private partnership. This one, the fifth one. So Karnataka government handed over the hospital to Apollo. Apollo did not do anything that it said it will do as a performance. So 10 years later, Karnataka government wakes up and then sees that the number of beds are not increased. Some of the faculties that they had to include, like nephrology and all, never got started. BPL people were BPL Mike is below poverty line or economically weaker section, if you understand them. So they were never provided free services, more claims than the number of people provided services, all sorts of misdemeanors happened because of the unequal power relationship. Karnataka government was desperate, was very weak, handed it over to Apollo, which was very powerful, and that is what is called as supplier hold-up. Where there is high asset specificity, because complete contracts cannot be written, there is always a chance for supplier hold up. There is in about 20 to 25 papers that have come out in the UK context of the PFI. Lonsdale and Watson have written enough about it as to how each time the government, having come thus far, having gone ahead with the construction and with all the tendering and all, could not take back despite underperformance by the contracted provider. And that is a classic case of supplier holdup. And in India, we created much more record. The first one, Navyuga Constructions won the bid for constructing the airport. Midway through the construction, it said it has no money. It has zero liquidity and it cannot complete the project. So what should have happened in the normal course? Anybody? What should have happened?
Can you repeat the question, please, Prasanna?
Navayoga Constructions in the middle of the airport construction raised its hand and said, I can't do it because I don't have money. I won't be able to complete the project. So what should the government have done in the ideal scenario?
Given the contract to another company?
So natural, no? But what the government did, and I think there is no
They
precedence for
provided
this in the
fund
whole world.
themselves.
No. It allowed for the collection of tolls
Okay.
even before the completion of the project.
Oh.
At least 2 years before the road was fully constructed, Navayoga started collecting the tolls.
My God.
So instead of penalizing the company, they have in fact asked taxpayers to.
Yeah.
Yes.
Okay.
And that is the beauty of supplier hold up. That's the word. What's it? And
Supplier hold up.
Lonsdale and Watson have fantastically told in each case of UK PFI how every case has been a supplier hold up, because calling for tenders, drafting tender contracts, drafting technical bids, assessing the bids and all have huge transaction costs. So what Williamson talks of the transaction costs of contracting. So you have to write full contracts on top of it. And you cannot write full contracts for market failure services because of high asset specificity. And because you have gone through so long with the particular provider who has won the contract, it's very late. It would be too late for you to cancel, reopen, re-tender. I mean, it involves a huge amount of costs and political risk also of not completing the project within the election cycle. All of you getting this complete scenario? And that is a classic case of supplier holdup. So supplier starts blackmailing. How many of you have seen the blackmail that happens every year by the private providers of Arogyashrees and Ayushman Bharats, telling no, this money is not enough, we are not going to provide services, and the next day the government starts revising the prices.
Have I understood correctly, Prasanna, that the only person who is in the example of this road and the airport road and the airport construction as is Navayoga, the only person who essentially gained from this was Navayoga?
Yes, definitely. They always gain. Otherwise, why would they be in the business? So whether we should be part of that business is the whole game of public-private partnership. And again, if you look at this from the measurability, contestability metrics, it becomes very clear which ones have worked and which ones have not worked. For example, public-private partnership in the context of ambulances have reasonably worked well. The EMRIs, no, the emergency medical services, because again, measurability is high, contestability is relatively low. Are you getting what I'm telling? Very high. Are you getting?
Yeah.
And that is the reason the only place where there is a reasonable amount of quote unquote PPP, and we don't talk about PPP anymore, it is public-private interactions. And the only place where it has worked is in the context of ambulances. Again, coming to this economic ways of looking at this, one thing that is not in this, even for example, if I were to buy canteen services, there is a social justice angle in terms of employer contracts, in terms of what you call social security for the employees, in terms of positive discrimination as in reservation. So none of these are being talked about as yet. And just I explained only the economic framework. Am I clear? If you are to look at the social justice angle, even this amount of buying cannot happen. I mean, even this small segment of buying, no, cannot be possible. Contracting per se is injustice because it doesn't take care of social security. It doesn't take care of positive discrimination like reservation. It doesn't, because the market logic is not amenable to equity. Am I making sense? Any questions? Oh, sorry, Mike, your question. Yeah, deficits are definitely not the issue. And that's the whole story of Greece as a country. So the fundamental macroeconomic way of handling things is when you have what you call depression in the economy, the government steps in as a big time purchaser, spurs the demand, increases the demand by constructing roads or whatever, and then thereby revs up the economy. But Greece, because it was part of the European Union, and European Union has very strict budgetary deficit targets. So Greece was caught up in a downward spiral. Neither was it able to spend more, neither was the economy picking up. So it became a it was a downward spiral, not even chicken and egg story. So Greece never recovered, and neither are Spain and Portugal recovery. Precisely for the reason that the European Union has very strict budgetary deficit targets. It should be in that band, and you cannot step in as a big time demand generator. And that means your economy is always in a downward spiral. Yeah, so deficits only when it comes to services. But when it comes to defense, when it comes to bailing out the banks, when it comes to corporate write-offs, deficits don't matter. And that's exactly the ideology. Yes, IMF and World Bank anyways had their neoliberal prescriptions and structural adjustment ones. But the foreign currency, the euro issue, because it was part of the eurozone, it had the fiscal deficit as a big constraint. Yes. Any questions? Yeah, Mike, you had a big one which you asked. 1 second, let me see if I can.
Yeah, I know you can't answer the whole question, but are you hopeful? That's what I was really wanting to find out. Are you, because you know we talk about social determinants and acute services, hospitals and primary care and all, can't deal with all of that, it seems to me. Only interdepartmental focus of entire governments have to have it as a focus to eradicate, so that people have properly housed and have a job and all of these things to flatten that social gradient of health and life expectancy. And what I don't see that in our government, and I don't know whether it exists anywhere. But is there any hope for it? I mean, do you have hope for that?
No. We have the ideal to strive for, and that is the ideal of health in all policies, as they say. I mean, WHO keeps coming up with these jargons and statements, as you very well know. So there is something called health in all policies. So your health is not achieved through health systems at all. Health has to be achieved through what you do in trade, what you do in your defense, what you do through, where are all those actually matter for health more than your health systems. And that is, I think, the story more or less of, for example, Cuba. Of course, people can say the size of it, we don't know, it's a black hole and all of those, but the focus of health, Brazil to some extent, given the size of the nation, does achieve some of these aspects. Vietnam is a good example. Of course, we haven't had the ideal of anywhere governments being very, very proactive for health of the people. It's always been pro-business.
India could be the first one.
Who?
India could be the first. It's big enough. It's got enough natural resource and everything to do it.
No, we are busy waiving off corporate taxes to the tune of billions of dollars, but not wanting to invest in health. So anyway,
sorry. Yes. Okay. Thank you.
Yeah, we are at 8:32. So, Prasanna, anything you'd like to add? If anybody has any questions, and then we can maybe wrap up.
I have one thing to add. Please engage. Please use the discussion forum. Please use the feedback liberally. Please engage with the feedback. It could be very useful. I hope I was useful anyway. So
could I just say how clear your talk has been to me as to why markets are inappropriate for healthcare. You've made it really clear. You've analyzed it so clearly for us. Thank you.
My pleasure. Yeah, so please use, I will also upload the PPP evidence, one big one that Nandi and Baru have brought out, which is a very useful one. But then there are enough horror stories. One last point. Sorry, 1 minute story that I have to tell. So Karnataka government, the state in which I am in, came up with this brilliant idea of having a vision committee for the health of Karnataka. So, and then the vision committee was headed by a public sector, well-meaning public sector person. And then he was the chairperson. And then they divided up into subgroups. And to his horror, all the subgroups came back to him telling PPPs have to be done, PPPs have to be done. And then he was wondering, where is this coming from? What is this PPP and all? So it invariably landed up with me. And then I had to write a policy note. So rubbishing and giving evidence of all where PPPs have not worked and everything. At the end of it, the chairperson came back to me, Prasanna, please don't be so radical. So I had to modify the chapter and then say how to make PPPs work. So that's a chapter that is there in a policy document of Karnataka government. So you can, I will also, I think I put it up on the group. And the second thing is we wrote Pathway to Universal Health Coverage. We were part of a group. And then we rejected all forms of PPP. And then the finance minister came back. Mind you, the finance secretary came back telling, don't we have any role for public-private partnership? And then I had to present a rebuttal to the government and then give again evidence of why it has not worked and what it means, and also just a note on the side as to the romance of the governments with this public-private partnership.
Thanks, Prasanna. I have some questions, but I'm going to keep them for the discussion forum. Thank you, everybody, for attending and spending time here. And hopefully, we will have yet another session. Looking forward to everybody's feedback. Thank you, Prasanna. Good night. Good night, everybody.
Thanks, everyone.
Thank you, Prasanna. Bye.
Bye.